Hi everyone. I really apologize for tonight late attendance. We had really some technical issues with our screens with GoToWebinar site, but here we are now, so we finally made it. Thank you for joining for tonight's webinar, everyone. My name is Jasmina Alagic and I'm an accounts manager here at Erchonia EMEA. Tonight's webinar will be hosted by Martine Silverman. Martine will guide you through the fascinating world of Lunula non-thermal laser, shedding light on its revolutionary impact on nail therapy. For those who don't know Martine Silverman is director and podiatrist at the London Nail Laser Clinic in the UK. She qualified from the Birmingham School of Podiatry in 1996 and spent the first 10 years of her career in the NHS in London before working in private practice. In addition to running a busy clinic, Martine carries out training for practitioners across the globe who wish to treat their patients with laser therapy. She also offers ongoing support to current practitioners. Martine has lectured to many medical practitioners within Europe and further afield on the use of laser therapy for onychomycosis and other nail disorders. We will be happy to assist you further at the end of the webinar, which for your reference will be recorded and sent out to all the attendees. I would like to alert you to the question and answer box on the right-hand side of the screen, which you can use to type in your questions to Martine. We will be addressing these questions at the end, but please type them in as we go along. Without further ado, over to you, Martine.
Okay. All right, thanks everyone for coming today. And yes, sorry about the delay. I'm really not very technical, but I'm very good at using a Lunula. So I guess that's the important thing. Okay, what I am going to just do is I want to just move that out of the way. And hopefully you can all see my screen, which says on it, Lunula's place in clinical practice. So the objectives of this webinar today is really just to introduce you to Lunula, explain how it's a really useful tool in clinic, and teach you a little bit about how low-level laser works, and so that you can just see nails with a few different pathologies and how they benefit from Lunula. So a little kind of overview, not so much of my career, but of the London Nail Laser Clinic. So I set up London Nail Laser in 2009. I brought over from the US the pinpoint foot laser, which was the first device that was authorized for elimination of fungal infections in nails, so onychomycosis. Pinpoint is a thermal laser, 1064 nanometer. It essentially works by killing fungal spores and fungal infections using heat from the infrared diode, and it's very painful. It's very destructive, and actually was probably only about 50% effective in clinical practice. I didn't really like using it. I used it for 3 years, and in 2012, I was fortunate enough to get an email from a friend of mine who is involved in aesthetic lasers, and she had seen this little box in the corner of a screen on, at that time, Prim Cogent, who was a distributor of Lunula in the UK and in Europe, and I sent out a contact me email. Anyway, I saw the laser in, I think it was June or July, June 2012, started using it in July 2012. By August 2012, I'd ordered another one. The original plan was to use both Pinpoint and Lunula. That lasted about an hour before I said I'm not using Pinpoint anymore. And I used it quite nicely for probably, I don't know, about 8 years. I played around, and I had other podiatrists working with me. We played around with protocols and, you know, tried to see how we could work it best. And then COVID hit. And in 2020, when COVID hit, I was shut for 3 months. And when I reopened, slightly panicked about all these patients that I'd started treatment with and how bad their nails were going to be, I saw quite a lot different to what I was expecting. So I then went back and really thought about what was going on. So the people who I saw back mid-treatment package, their nails were looking so much better. There were a few that weren't, but essentially it just made me think about really how I treat and what I was treating. And what I realised was, first of all, around that time, there were far fewer active fungal infections and far more damaged nails to be seen, possibly because of the restrictions with the pandemic and people not going to work in the same way, so therefore not wearing the same footwear, not going to gyms, not going to hotels and on holiday, and lots of different things going on. We had a fairly decent summer in the UK then. Lots of people were wearing flip-flops and sliders. So I started to think a lot more about the risk factors of damage to nails, because you can't get a fungal infection, you can't get OM without damage to nails. And past the risk factors of a fungal infection and damage, what actually goes on with patients, what affects their nails. Looking back at photos, and I take photos all the time of patients' nails, where was our starting point? What did I diagnose and what did I see? It took me a little while, but essentially since probably the end of 2020, I have changed my protocol, very different to Erchonia's protocol, and I'll explain a little bit about that later. But for the last couple of years, certainly I've been getting the most phenomenal results. Lunula is a great asset to my practice. However, it is something that I use in conjunction with my podiatric skills, with education, with a few other bits and pieces. So let's just move on to nails. And for me, the important thing when I am in clinic and I'm looking at people's nails, it's not just appearance, and it's not, necessarily all of the nail that's a problem, because nail plate, is dead. So that's what tends to be damaged. Without damaging the nail plate and breaking one or both of the sills that we have, people don't have a problem. So our cuticle is our proximal sill, natural sill, that stops pathogens getting in. And our hyponychium at the distal edge is the sill there. If either of those are broken, and generally it is the hyponychium, then we start to have a problem. So let's also look at how nails grow. And all this will kind of come together a little bit later on in why I treat, in the way I treat, and why I use Lunula. So if we start, nails start to grow from behind the proximal nail fold. So if we go back, for those of you, and I have no idea what professions people are in, what professions, if you're distributors, your clients may be in, whether they're dermatologists, whether they're podiatrists, whether they're in a beauty field, I don't know. But I can only talk as a podiatrist, because I've been one for almost 30 years, and how I look at the problem that faces all of us when it comes to patients or clients who have nail problems. So your proximal nail fold over here, with the cuticle attaching that to the nail plate, and the matrix is behind the proximal nail fold. So as the cells start to come out, they then have to attach to something. Otherwise, they're not going to get very far. They're just going to detach and crumble. When we look at the cells that come out, they're pushing out all the old damaged cells. And the old cells generally are flat, they're fairly hard, they don't have good integrity. And the newly formed cells need to then start to slide up towards the hyponychium. Your nail bed, so the skin underneath the nail, is kind of shield shaped, and it has very distinct borders. When the nail plate gets damaged and it lifts in any part of the borders, what happens is we lose that distinction. And I'm going to show you some photos later on of nails that I've treated and you'll see I'll point out to you where the borders were, where the borders will be, and then hopefully on the after photos you'll see that the borders are starting to come back a little bit. So toenails grow an average of 1.62 millimeters a month, and that's about 3 times slower than fingernails. I treat both toenails and fingernails. I treat them slightly differently because their environment is different. Obviously, fingernails are exposed to higher volumes of blood, and they grow faster. So during the day, nails grow faster than at night. During the summer, nails grow faster than in the winter. We also have to take into consideration things like footwear, socks, people putting cream on their nails and softening them, and various things that can affect the growth of the nail. In addition to the local environment, you've got the systemic environment. So people's health plays a really big part in nail growth, in the same way that if you see someone who has had a period of poor health, both physical and mental, you see, you know, their skin looks a bit grey, they're certainly not glowing, their hair looks quite lank. Skin, hair, nails, all made from keratin, all affected by the environment, physical, mental, local and systemic. So why are there so many patients with nail problems? Well, risk factors are the thing that I look at the most, and you have obviously acute trauma to nails. So a patient who drops a brick on their toe is unlikely to do that again. That's not a massive risk factor. It may well be a reason for a patient coming in. I've had a few over the last few months who years and years ago, decades ago, had trauma from horses stepping on their toes, and their nails have remained, or the nail affected has remained the same over maybe 20 odd years. They've never been able to help it. It's not grown properly. It keeps detaching. They try all the things you can paint on. The doctors say, oh, you've got fungus. They haven't got fungus. They've just got damage. And I'll show you a patient later who I have a nice timeline of her nails. There were no physical clinical signs of onychomycosis at all, but damage, not from a horse as it happens. And you'll be able to see how the nail has grown out over about a 2.5 year period. So risk factors, the biggest risk factor that I see with patients is footwear. And I think we're all guilty of, you know, buying a pair of shoes, wearing shoes that might be too small. Most of us don't have our feet measured from about the age of 13. And whilst we might stop growing and our feet don't necessarily grow in length, what does happen is they absolutely grow in width. So as we get older, our ligaments get more lax, particularly women, and particularly during pregnancy or during the menopause, or even certain times of the month where our hormones are involved and our feet widen, our arches drop, and the shoes that we wear are too small. They don't have the width in them that we need. In order to get that extra width, you would need to go up a size in footwear. Most of my patients, when they stand there with their shoes on, I say to them, just stand for a minute, let's be quiet, tell me what you can feel. And they say, no, I can feel the top of my shoes on my toes. That's not good. And that's without even walking. When you walk downhill, feet have to move forward, slip forward so that you can propel yourself off. But when you're standing there with a pair of shoes and you know, patients say to me, yeah, these shoes are absolutely fine. And then we look into it, and if you draw around the patient's foot when they're standing and try and cut that out and try and get that into the shoe, it will crumble up because it's just not going to fit properly. Shoes nowadays are made really poorly. They are made with less material than they used to. When I was at university, we have in the UK, we have probably the best known shoe company is called Clark's, and they have a factory down in Somerset, and they train podiatrists to measure feet, and they showed us how they made the shoes. The lasts that the shoes are made from are now a lot smaller than they were 20, 30 years ago, and the shoes themselves just are not as good quality. On the plus side, trainers tend to now be made with much softer material than they were back in the 1980s, 90s, 2000s. So even when they're a little bit small, actually they don't cause so much damage. And an example of that is my 18-year-old son, who is in his last year at school. And before he broke up in the summer, he had on his games kit, his PE kit, and his trainers. And I looked at them and I said to him, "Your shoes are too small." "No, they're not. They don't hurt. They're absolutely fine." And I could see his toes were right at the end. I could feel his toes were right at the end. But of course, my 18-year-old non-podiatrist son argued with me. Anyway, a couple of weeks later, we went and got his feet measured, and a size and a half larger. He said to me, "These feel a bit more comfortable. I hadn't realised the other ones were actually hurting." And this is so true. We have busy lives, we get on with things, but day after day after day, we damage our nails and our skin with shoes that are too small. And, you know, when I talk to my patients about it, and the analogy that I have is when you go to the dental hygienist and have your teeth cleaned and your plaque removed, the problem that we have is we come out and we eat and drink again. So even if we brush teeth and floss and use mouthwash and all these different things, we're going to get a build-up of plaque over time. In the same way that we damage our nails, even when we wear shoes that do fit well, at some point we'll probably get some damage. And for some people, they don't recognize that damage, they don't see it. It heals before they have a real problem. For other people, they're not quite so lucky. So risk factors, shoes are the biggest one. It's constant damage. The second one are things like sport, health issues, medication, nail varnish. There are so many risk factors, but these are what start to form the basis of my diagnosis with patients. So misdiagnosis. I have lots of patients who come to me, and in the form that they fill in online when they book their appointment, it says, "I've got a fungal infection." And then they turn up, fungus isn't their problem, damage is their problem. And these people have tried systemic medications, topical medications. Their GP has just had a quick look and said, "You've got fungus." Most of them don't ever have mycology done. So there's no positive culture that comes back telling us that there's fungus. Occasionally that does happen. But most people, if they have had a fungal infection 5, 10, 15 years ago, and they've been treating it, and they've either taken medication or they've used topical solutions, they may not have a fungal infection anymore. But these treatments for fungus, for onychomycosis, do not necessarily get rid of damage. So the times when systemic medications work are in the early stages of a fungal infection, when they do kill off. They're brilliant at killing fungus, but once you get to the point where the fungus has really got deep into your nail bed and your nail is detached and you have damage there that cannot fix itself, that's where Lunula comes in. That's not where you need to have terbinafine or triconazole and all the other systemic meds, or even the topical treatments. They don't really help very much. So barriers to treatment, well, you know, patients go through all the normal treatments, as I've just said, but because they've got damage and they continue to damage, we can't get rid of their damage there, even if we get rid of their fungus. So patients tend to come in, they've tried everything, they're not working, and then they go for laser treatment. They may have had thermal treatment. I had a patient in today who, February last year, she had an accident in the garden and she was sawing a branch and she damaged her thumb really severely. The damage to the actual thumb has healed, but her nail has never healed. And she's been given antibiotics, she's been given fungicidals, she's been given all these different things. She's used paint-ons for many months, and nothing has helped her. And she has actually recently had a sample come back as candida infection. I don't believe that's from the original trauma. When she had the original trauma, mycology came back negative anyway, and she actually showed me photos of the original trauma, and there's no clinical signs of fungus there. Now, because she's had a damaged nail that's been about 75% of her nail is detached on her thumb, and she's now got candida there. She has her hands in water a lot. She has a dog that she it gets very mucky every day. She washes him at least once a day. She still does a lot of gardening. So now we have to move on to something that is going to work from the inside out. And actually, she really didn't get on with systemic medication. She had migraines after a couple of days, so she doesn't want to take those at all. So we tried today the first Lunula treatment, and we will review in 6 weeks, and I'm pretty sure that we're going to start to get a really good reaction and response. Lack of preventative education. You know, if patients go to their doctor, their general practitioner, all they'll say is, you've got a fungal infection, use this, take that. They don't educate at all. So patients continue to cause a problem with their nails, be it with footwear or be it with pedicures, with gels, with nail varnish, with all these different things, walking around a gym or gym changing room barefoot, lots of different things. So this is where we come in. And the lack of understanding about nail damage. Patients don't understand, and I don't think doctors necessarily in the UK, general practitioners, understand that once a nail is damaged and the older you get, the less chance you're going to have of healing this nail. So because nail plate is dead tissue, we have to heal what's underneath it. We have to heal the live tissue. I don't know anything that heals that, any medication, any treatment at all, even nail reconstruction. All these things don't heal a nail bed or a nail matrix that may be damaged. With patients coming in to see me, they've tried to cover their nail up for years, which has caused further damage. So we have to look at that as well. So let's move on briefly to lasers. I'm going to give you kind of an overview of excuse me, of Lunula and how low-level laser therapy works, but I'm not a physicist. I do understand how they work, but I'm not going to be using particularly long words and going into the physics of Lunula. There are people far better qualified to do so. So Lunula is a class 2 device. I think it's class 2B, which essentially means it's incredibly safe. It's low power, it is high energy, but it's low power. It's not going to cause any damage if it's used properly. If you were to sit with your foot in it and keep on pressing the button, I'm sure we'd get to the too much of a good thing. But how we use it in clinic is simply, it can only do good. At worst, it does nothing at all. But I don't ever get that with patients. Something happens, the nail changes in some way, the skin changes in some way if it's not doing too well. So it's a very, very safe device. You don't need goggles to use it. The diodes are at the top of the box inside, and I don't know anyone who can get their head into the laser and look directly at the beams. It's non-thermal, so it doesn't give off heat. It's dual diode, 405 nanometer beam and a 635 nanometer beam. So what's laser? Light amplification by stimulated emission of radiation. Bit of a mouthful, quite a nice acronym, but the really important thing is light. So light helps us to live. Light keeps us alive, and light essentially just makes everything better. You know, in the winter in the UK, there's a thing called SAD, seasonal affective disorder. People get really low because often, and it hasn't happened this year, it's been quite bright this year and quite a mild winter so far, but essentially it's grey, it's rainy, we don't see much sunshine at all, and people get really low and their vitamin D levels get very low. So sunlight, sun is a laser. Essentially, the beams that come off it are not visible light like Lunula is, but it's just kind of to the right on the electromagnetic spectrum. And it works in the same way as Lunula does, in that it works by photochemistry. So with Lunula, we have visible light. What you see is what you get. Monochromic, one is red, one is violet. The whole way across those beams is the same amount of energy. They're coherent collimated. So as they rotate around in the box, you're getting a set dosage of laser. Different lasers use different wavelengths. So the higher the wavelength, the more heat there is. So infrared is a higher wavelength than Lunula is. The lower the wavelength, the more energy we get. So we don't want heat, we don't want discomfort, but we do want high energy that the cells can take up and can convert to chemicals. So wavelengths between 400 and 700 nanometers. So remember, we're using a 405 nanometer and a 635 nanometer beam. They're within the visible light spectrum. Anything under 400 nanometers is invisible, and anything over 700 nanometers is invisible. Wavelengths above 700 go into the infrared light spectrum, and then they start to get a little bit warmer. So how Lunula works. Low-level laser therapy, or photobiomodulation, stimulates healing in the body by photochemistry. Photochemistry is photo, light, and chemistry, the chemicals that the body makes in response to that light. So we have photoreceptors, things that receive the light in our cells, in our mitochondria. In fact, I'm sure many of you will know this. And as a result, certain chemical reactions become triggered. And the target of the laser beams is cytochrome C in mitochondria. We then get a cascade of events which result in increased hydrogen peroxide from the 405 nanometer beam. That's what kills fungus. And nitric oxide from the 635 nanometer beam. That increases the volume of blood in the area and elicits an immune response in order to regenerate the tissues a lot faster than they would normally. So this is a better way of explaining it than just words. On the left-hand side, you have your light, you have your Lunula, 405 nanometer and 635 nanometer. As we use that for the 12-minute cycle, it starts to activate our photoreceptors, so our NADPH oxidase and our cytochrome C oxidase. And they then start to produce a primary response where we get reactive oxygen species and adenosine triphosphate and reactive oxygen species. And then we finally get our secondary response, which is what we've been waiting for, where the ROS is converted to hydrogen peroxide and the ATP is converted to nitric oxide. So very simply, two diodes from the laser, from the Lunula, will have a positive effect on the nails, because what we're doing is we're increasing hydrogen peroxide by about 25 to 30% more after a Lunula treatment. I have no idea how long it takes the body to use up that hydrogen peroxide. I would expect it depends on how much it needs. If there's fungus there, if there's other pathogens there, how much is there? And once it's used what it needs to use, then if there's any excess, the body will just eliminate it. We produce hydrogen peroxide naturally anyway, but it seems we don't produce enough naturally to get rid of any kind of fungal infection, be it onychomycosis, tinea pedis, candida thrush, ringworm, squat rot, anything at all. We tend to need some help. So Lunula helps us with that, but it does it in a natural way without putting medication, without topical solutions. And a lot of patients use hydrogen peroxide as a topical solution. As a podiatrist, many years ago, we used to do that. We used to have a little brown bottle of it and dip our cotton bud in and paint it on top of the nail. It very rarely got through the barrier there, so it wasn't really going to get into the nail bed in order to actually get rid of the fungus that's there. But when we use Lunula, we do it from the inside out. That's a great way to. Systemic medication obviously also works from the inside out, but it goes through the liver and it causes other problems. So once we've managed the fungal part of it, and I'm sure you've been given clinical trials and the FDA studies and all these things which show just how effective Lunula is. Depending on which study you look at, I think one of them even got a 97% effectiveness rate, and that's based on getting positive mycology, treating weekly with Lunula, and then negative mycology and retesting again at certain intervals. They make very good reading. So that's fungus taken care of. the bit that is interesting to me, as it happens, is the 635 nanometer diode. So the one that stimulates healing, it's used in wound healing, pain management, pre and post-ops, loads and loads of other things. I believe it's been used in lots of research on the brain as well. It's a really great laser because it just gets the body doing what the body needs to do, but quicker than it's going to anyway. So we increase the nitric oxide in the area. This time I don't know how much we increase it by, but it's a really powerful vasodilator, so we are increasing blood supply to the area. I had a patient actually during COVID who I didn't treat her nails in the end, but she came in, she has multiple sclerosis, she is very young, in her 20s, in a wheelchair. I didn't think that it was worth her while at that point using Lunula to treat her nails because I didn't think we would get a good enough response for her, and she had so many other health issues to deal with. But we did carry out one Lunula treatment, and the reason I did it was to see her feet were like blocks of ice, and this was in the summer. They were so cold, and so because of COVID I had a surface thermometer, and I used that to just see if there was going to be any change before and after carrying out a Lunula treatment. And her surface temperature increased on one foot by about 1.2 degrees, and on the other foot by, I think it was a touch under a degree. And it was quite amazing to see this was an immediate response from her. And I know that there's Dopplers have been done which show the increase in blood supply before and after the increase after the Lunula treatment. So it really does help. When I see patients who've got fairly poor circulation, and sometimes as their feet go into Lunula, they look really, kind of white, pale, not particularly great in colour. When they come out, they just look that little bit healthier, a little bit pinker. And patients tend to say that they just feel healthier over the next few days. They tend to just feel a lot better. So the effect of the 635 nanometer diode tends to last about 6 weeks or so, and you get your immune response, tissue regenerates. And when I see patients, and I'm not concerned about a spread of fungal infection, and I'll show you some pictures later and explain how I've treated in the intervals between treatment. But for those who have damage rather than an active fungal infection, I treat usually 6 to 8 weeks apart, and we tend to see much better growth going on. When you treat weekly with Lunula, you miss out on some of the additional effects of the red laser because there's only so much dilation you can have in blood vessels, only so much increased blood supply. It's not, if you keep on treating close together, you miss out on that, but you do get the hydrogen peroxide increase. So how we deal with these unsightly nails? Well, the first thing is diagnosis. When I look at a set of nails and I look at damaged nails, I'm looking at the appearance, but more so the texture of the nail, how attached it is. I look at the history of the problem, the history of the patient, if there's positive or negative mycology. Most of my patients will come in and tell me they've got a fungal infection. A few of those patients will have an active fungal infection with acute tinea pedis, so athlete's foot, with spread of infection. You can see they look very yellow, they're very crumbly, they sometimes smell, there's a pasty load of tissue underneath. Those are the patients that I say, yeah, fungal infection, we'll start treating close together. The next lot are those who have a chronic infection. So there's still the discoloration that's kind of left over from fungus that's there that may never have been treated. The nails are still quite crumbly, but they haven't really changed in the last few years. The skin is very dry and flaky, but it's not itchy anymore. There's no little red spots. So it's kind of moved on. Like any systemic illness that people have, you have acute, you have chronic, you might have flare-ups. So this is kind of thing we're looking at. And then you've got patients where there's no clinical signs of fungus at all, either in the skin or the nail. Usually it's 1 or 2 nails that may be affected. You can often pinpoint the damage when it happened, how it happened, and nothing has really changed from there. So those are the patients that don't have fungal infection, but I still treat with Lunula, and we get some great results with those. The risk factors we spoke about earlier, these I need to, when I'm carrying out my consultation with my patient and deciding whether to treat with Lunula, how to treat, I then have to discuss with the patient how we manage these risk factors. So acute trauma, very easy, doesn't tend to happen very often. Once you've dropped a brick on your toe, you don't carry a brick around. You just act very differently. Footwear, we can change that. That's pretty easy. Sport, I would never ever tell anyone not to do exercise, not to do sport. What we do is we work around it. So I might suggest something like bigger trainers and a gel cover to start to take some of the pressure away, keeping nails short, just ways to prevent getting more damage to the nails. Ill health. So interestingly, gut health, and I'm sure many of you have heard Robert Silverman, no relation, but Dr. Silverman out in the States talking about gut problems, that you tend to get leaky gut syndrome. I think there is a real connection between leaky gut syndrome and nail fungus. And in some of my patients, when we look into why they've got a problem and it's recurrent and it's really difficult to get rid of, even with Lunula, and we look into their health, they tend to have colitis or Crohn's or IBS or some problem with their gut. And I think since COVID, there's a lot of people with leaky gut syndrome. They have, have had an infection of some sort that has then manifested in other problems, and nails ultimately become infected because they become weakened. There's a systemic infection there somewhere. So I look at all factors, and we then try and go down a more holistic route. You can laser, not with Lunula, but with other lasers, the vagus nerve, the gut, and try and fix things in that way. I think there's a lot more to come out of leaky gut syndrome than we know at the moment, in regards to people's feet and their hands as well. So manual podiatric skills, debriding nails, I cut nails, I use nail nippers, I use burrs, and a powder spray drill. So I really take down, I reduce the nail, anything that's not attached that is kind of hanging on by a thread, I reduce, I take it away completely. What I don't want is a loose nail sitting on a nail bed with a nice gap underneath where fungus can be harboured. Or when you've got a loose nail sitting on a nail bed and you walk, the loose nail hits on the nail bed, so it bruises it and damages that more. So it's really important, I think, to make sure that nails are kept short. Anything that doesn't need to be there that's not healthy should be taken away. And this is something that we do regularly with our patients. And when I'm treating them with 6 weeks or 8 weeks in between treatments, the nails grow enough and I debride them at every appointment. So, Lunula, how many times? Well, I carry out 4 treatments for toenails. For fingernails, I will treat treatment by treatment and see if we need to continue, because they do respond a lot faster. But I generally carry out 4 treatments on toenails, and often the intervals are about 6 to 8 weeks between each appointment, unless there is a risk of spread, imminent risk of spread of a fungal infection. Occasionally I carry out more treatments, but generally not straight away after the 4 treatments. So it might be 6 months later to give the nails a boost and to give the area a boost. Or it might be in response to a patient getting a new infection. So I have patients this time of year who go skiing, and they often come back with damaged nails and a brand new bright yellow superficial infection. And then I just do 1 more treatment, or sometimes 2, and it goes very quickly. Education, that's really important with patients, because they might know how they got an infection, but they don't know how to deal with it and how to prevent it happening again unless it's really obvious. They think that using nail varnish is great because it covers it up, you can't see it, but in actual fact that dries out the nails and causes lots of problems, weakens them as well. They don't know what signs to look for when they come in. Suddenly they just say, you know, I've had this problem with my nail for years. I don't even really remember what it looked like when it started, but we then go through how to look after other nails as well as healing this one so that they don't get that problem again. So this is active infection here. Bright yellow. You can see this was on the same day. This was before I debrided the nail. This is when I cut it right back. The infection was all around here. I carried out 4 treatments on this patient in a period of October, November, December, so 3 months, just over 3 months. This was the 23rd of January was his 4th treatment. And you can see that this nail is growing back beautifully. It's attaching, it's got a little bit of a way to go. But I said to you earlier that I would talk about the borders of the nail bed. So here you can see the nail bed is just starting to lose its definition at the end, where this is the hyponychium. Here, as the nail is growing up, the nail is on here has come just above the border, and I can see, it's difficult to see by photo, but when I can see it face to face, you can see more of a border there, which will just be pushed into a really nice little shape where the nail bed will be nice and curved and the nail will grow over it properly. So that's your active honeycomb mycotic nail. This one is a slightly different one. There's no fungus there, but there is bacteria. There's Pseudomonas. This patient in her 50s, getting on for 60s, was on holiday, and she said the pool, look, she had gels on her nails. She often has them painted, but she said, you know, one day the pool looked really green and then they couldn't use it because it was being cleaned. Clearly there was bacteria in that pool and the filtration system and whatever hadn't worked particularly well. And she had ended up with a very localized Pseudomonas infection. And again, I cut that right back. I filed back as much as I could. And after this was at the 4th treatment again, so in a similar sort of period of time, that got rid of the infection and the nail was able to grow, and we could see a faster nail growth than we would have done ordinarily. And the new nail is looking absolutely perfect. Excuse me. So this patient is a dancer and she is in her late 60s, I think. She doesn't really have too many health problems, but she dances a lot and she has nail varnish on constantly. And so when she came to see me in July, this was what her nail looked like. This is what it looked like once I had taken back. So she had very little nail still sitting on the nail bed, but an awful lot of damage there. And we've done 4 treatments. In between the treatments, she has had one holiday, which was a dance holiday. So she was dancing all day, every day, had her nails painted. She often wears red nail varnish, you can kind of see remnants of it around, which I couldn't get off. But her nails starting to grow back really nicely. She still dances several times a week and wears, although she wears open dance shoes, they have a strap that tends to come over the nail, which is unfortunate. So she can often feel that pressing, but her nail's healing really well. Excuse me. So this patient was actually her thumbnail. She has arthritis. Her thumb is all quite deformed, and she has had a problem with the nail for years, just hasn't really grown properly. It gets to a certain stage and then it tends to come off. We only did 2 treatments. Well, actually, I have done 3 treatments because I did the 3rd treatment in November at this appointment. But between these 2 dates, she had had 2 treatments. One on the 1st of August, which 6 weeks later was followed by another treatment. And then I saw her 8 weeks later on the 2nd of November. And where her nail hadn't previously attached, it's now starting to attach really nicely. And I haven't seen her again since, because she's looking after her husband, who unfortunately had a stroke and is now pretty much completely blind. So they don't really go out in the winter. So I'm hoping to see her maybe in about March time and see if that nail has grown up fully. Hopefully it would have done. This patient is someone, and you'll see, I mentioned her earlier, I have a whole timeline of her nail growth. She was seen before COVID, and actually she had 4 treatments the old way, so between a week and 2 apart. But she had no clinical signs of fungus at all, just sort of damage. And in almost getting on for 3 years, you can see the difference. But here we can see the actual timeline. So the first time she came in, this was before nail debridement. That was when most of it came off, and her nail bed was quite humped because it hadn't been held in place by a nail that was filling the whole bed. The next couple of photos were during COVID, when she sent them over. She had had her 4th treatment, I think it was literally 2 weeks before COVID shut us down, so beginning of March. And so this was her first review really after that. And you can see the nail was just starting to sort of get a little bit thicker, and just starting to attach a bit more. But a couple of months later, so there was no more treatment after the 4 treatments, the nail actually is looking an awful lot clearer. And then we just see it start to progress through the months. And it takes a long time, but as we got to November 21, it has grown really nicely over the border of the nail bed and is all fully attached. She then damaged it again with a pair of shoes, but actually it damaged the top but didn't damage the rest. And you can just see it growing out. And the photo she sent me, she has actually sent me a couple since, because she just occasionally sends them to ask if she should cut her nails. But you know, we're now 2024. I think the last photo I saw was mid 2023, and the nail was looking absolutely perfect. So, you know, it took a while for it to grow out and reattach, but actually it happens and it works really well. And I think now that a nail like this, I would treat every 8 weeks. So by the time the patient has had their 4 treatments, you're looking, you know, several months down the line, and the nail is probably almost fully attached at that point. And because I file it every time I see it, it grows really very well. So we're almost at the end of this, you'll be pleased to know. The summary. Essentially, Lunula, oh sorry, it's getting late now. Lunula is a source of visible light. We need light to help us live, and visible light stimulates the body to make chemicals to break down pathogens and heal the damaged tissues there. I use it in conjunction with my podiatric skills that I've honed over a few decades, patient education, reduction of risk factors associated with their damaged nails, increase in hygiene in many cases, and Lunula is used to help speed up the healing process. There's no other way to really speed it up. There's no tablets that can really help. We've tried lots of different things over the years, topicals, but actually this is certainly the best that we get. It's pain-free, has no negative side effects, and it encourages the body to work more efficiently. It's natural. It's a nice thing to use a natural treatment rather than a lab-made topical solution or tablet. And it gives patients healthy, normal-looking nails again. So that is that. Let me go back onto the webinar.
Well, thank you very much, Martine.
Okay.
This amazing presentation on the Lunula laser. thank you for hosting this webinar. I think that we have answered most of the questions we had from our attendees. Yeah, thank you.
Yeah.
Thanks to Martine for that. And thank you everyone who have attended also. Just to remember, recordings of this webinar will be sent out to all the registrants, so you will get your recording automatically sent to your emails. If you have any further questions to ask, please feel to contact us. Have a great evening, everyone, and thank you for tuning in. Bye-bye.
Thanks.